pupil is dilated and it was non-reactive as well. She had no history of any systemic risk factors. Her fundus was normal. So how would you like to proceed with this case?
I think we've seen one third now and we've talked about the various imaging. So we'll run through a bit, just like a recap.
Yes, so as it has already been talked about, that if a pupil is involved, one must always rule out space occupying lesion, specifically aneurysms. Aneurysms could be posterior communicating artery, or there can be any other artery aneurysm that can compress on third nerve. So how do you approach to such cases?
The pupil that we're looking at is the most important thing when you're looking at third nerves. If the pupil is involved, you're almost sure that you should at least image for the safer side. We've seen cases which are medical in etiology and would have an involved pupil, but usually you will err and look for an imaging technique. If the pupil is spared, if it's complete external ophthalmoplegia, then it's most likely that there's not going to be any progression and you're looking at vascular pathologies and you're going to evaluate for them and essentially follow up the patient initially a little closely to make sure that you are sure of your diagnosis is correct, and a little longer subsequently, particularly if you're planning any surgical intervention subsequently. If the pupil is if the ophthalmoplegia is partial, then you are better off doing an imaging because it may be a developing third nerve palsy.
So as Sir said, that indications for imaging in a case of third nerve palsy, specifically pupil involving third nerve palsy, is if the age is less than 40 years. If the age is more than 40 years, then if pupils are involved, one must image. If there is an aberrant regeneration without any significant history of trauma, or if the trauma is very trivial, one must do imaging because a trivial amount of trauma may not involve pupil. So we went ahead with imaging, and I would request Dr. Sanjay to give us information about imaging.
Okay, these are the representative static MR images of this patient, T2 weighted, post-contrast T1 weighted, and again post-contrast. Here there was an ectasia of the intracavernous part of the carotid artery, as you can see here. With this, one can see what looks like an aneurysm here, which was subsequently confirmed on the base images. You always go back to the base images from which those are the finer sections in which you can make a better assessment of the aneurysm, its neck, whether it's actually clippable or whether the patient has to go to a neurosurgery. So this is what it was, a PCOM aneurysm in one of the contrast enhanced images.
So the next question comes, if one has to do imaging, which is the best modality?
Well, in choosing in terms of a best modality, this is a slightly tricky question, CT angiography versus MR angiography. Well, having said that, gold standard is the catheter angiogram, which is the digital subtraction angiogram, which gives you an unparalleled diagnosis, not only to diagnose, but also to intervene and actually coil the aneurysm also. But that apart, between CT angiogram and MR angiogram, I would say it's more to do with the local expertise and the radiologist whom you refer your cases. For example, 64 slice CT angiogram, good, well done 64 angiogram on a 64 slice CT would be a lot better than doing a non-contrast.
So these are the various aneurysms that can affect third nerve. Now move on to second case. This is also a case of third nerve palsy. As you can see, this is a third nerve palsy of the right eye. But one can also see that this patient has history of hypertension, diabetes and hypercholesteremia. So in such a case, you may get away without doing imaging. You just follow the patient closely until the patient improves. If patient does not show any sign of improvement for another 6 to 8 weeks, then one must do imaging. So moving on to now a new case, case 3. He was a 48-year-old male who complained with sudden painless loss of vision in the lower half of the field, right eye. On examination, on examination, the visions are interchanged. The right eye, the left eye vision was good, 6/6. The right eye vision was 4/60. There was afferent pupillary defect in the right eye. He also had a history of hypertension for past 5 years. So the diagnosis as is quite clear that you can see on fundus photograph there is inferior disc edema, and there are some dilated inferior veins that suggest the diagnosis of ischemic AION. Now we have to differentiate the ischemic from the sorry, the non-arthritic from the arthritic ischemic AIN.
We rarely see so much arthritic, although we've presented cases, but proportionately the largest number of cases, in fact, I would say more than 90% of cases we'll see would be non-arthritic, and that's more important for us, although the Western literature does talk a lot about arthritic. Essentially, they are older, the arthritic group is older, you have severe visual loss as compared to not so severe usually in NAION. You have, of course, associated diabetes, hypertension. You have systemic history in the form of jaw claudication, generalized weakness, malaise, fever loss. So that's what you need to ask for if you're suspecting arthritic. And of course, marked increase in the ESR and CRP and the platelet levels. That's what is important. The important thing is that you need to treat very quickly arthritic. You need to really be very prompt in your treatment with steroids. Whereas NAION, as we've discussed, the management still is controversial with steroids. So, if you have an ischemic neuropathy, make sure it's not arthritic. If it's arthritic, we've discussed early intervention with steroids and a long-term treatment. Whereas NAION, you're more worried about treating the risk factors because it's been seen that the other eye gets involved over time in almost 30% because of the fact that their risk factors are not treated. So that's the most important intervention you can do, that is control the risk factors.
As far as the role of imaging, I would request sir to highlight it.
Well, the role of imaging until now has not been great. This is one sequence I would just like to highlight called a diffusion-weighted imaging. In this particular MR sequence, you pick up the cells with the abnormalities which have a restricted diffusion of molecules. Now, for me, this is like a stroke of optic nerve. So this is the imaging which has been taken almost like as an offshoot from the neuroimaging meant to pick up acute strokes. So consider when in a normal situation, when the cells are normal, so there's enough extracellular fluid between them to allow free diffusion of water molecules. Whereas if there is a vasogenic edema, a cellular swelling because of ischemia, the extracellular space is reduced and which gives rise to reduction or restriction of a diffusion, which is what this MR picks up. So what is seen here is at a bright optic nerve here. This is one of our cases that was picked up. Now, having said that, of so many cases that we see of clinically suspected anterior ischemic optic neuropathy, we have not been able to produce as good images, and this is still evolving. So, bright on diffusion-weighted imaging and dark on ADC maps. I'll not go into the jargon. So, this is what we call as a restriction of diffusion, which does support your clinical diagnosis.
Thank you, sir. So we move on to next case. This was a 13-year-old male with a complaint of gradual loss of vision in both the eyes, left more than right. There was history of recurrent fractures of bones, and on examination his vision in right eye was 6/18, in left eye it was 6/60. There was RAPT in left eye, and on fundus examination both eye had severe significant pallor. So we went ahead with the differential diagnosis. The most important differential diagnosis, what we thought could be a probably compressive optic neuropathy. The other differential included hereditary, toxic, or nutritional deficiency optic neuropathy. A choice of investigation in such a case is definitely MRI brain with orbits to rule out any intracranial lesion. So we went ahead with MRI. So would like to highlight the MRI features.
Okay, I can recall this is one of the patients in which when we reviewed the MR in the regular rounds, we found that this optic nerve appears a little too pinched to be normal. And more importantly, what we noticed was that there is marked thickening of the superior wall of the optic nerve. We didn't know what's happening. We wanted to go back to the CT because CT is where the bony details are unrivaled. You get excellent osseous details in the CT. So which is what we did.
So we went ahead with CT.
Yeah. So this CT again obviously shows a striking increase in bone density. So there is complete loss of the corticomedullary differentiation. All you see is just chalky white bones. So which is with marked compromise of the optic canal on the axial and the coronal sections. And also middle ear abnormality. I mean, it's all that you see is a dense piece of bone, so which diagnoses as a osteopetrosis, the TARDA or a late variant of osteopetrosis.
So it was the bony sclerosis which was compressing on the optic nerve. Now, if we can go back to our history, we can see that the patient also has a history of recurrent fractures of bone. So that gives us some kind of clue that there is something wrong with the bones. So we have this another case. She was a 25-year-old female, a 24-year-old female with a sudden loss of vision in left eye, with some retrobulbar pain on movements. She also had a similar episode in right eye. On examination, her vision in right eye was 6.6, in left eye it was 6.24. There was RAPD in left eye. Her color vision was affected in left eye but was normal in right eye. Same was with contrast. On examination, there was a mild, very minimal kind of disc edema in the left eye, while right eye showed mild temporal atrophy or pallor. So the diagnosis was probably clinically was papillitis. The causes could be anything. It could be demyelination, infection, or granulomatous, autoimmune diseases, or contagious inflammation from the sinuses, orbits, or meninges. So I would like to ask panelists, what is the role of systemic investigation, role of steroids, and role of imaging?
I think we've discussed that in our first talk, so we'll just go on to the imaging because we've discussed the role of IVMP or dexamethasone as in our center, and just go on to the imaging. So we'll discuss the most important part, what is important. Yeah, we just look at the imaging.
Okay, these are the representative MR images. This is actually called a flare sequence, in which this particular patient did show what looked like vertically or perpendicularly oriented periventricular hyperintensities, which were plaques. And the sagittal images, the midline sagittal ones, were almost diagnostic. What you see is the area foci of demyelination in the callososeptal or callosomarginal areas, which are almost diagnostic of multiple MS, established MS. Dawson's fingers, actually, they are called.
So sometimes it might be difficult to differentiate a multiple sclerosis from neuromyelitis optica clinically, but yes, MRI can help us in differentiation. This is how we can. Sir, would you like to highlight the radiological differences?
In the typical MS, you would expect to see more discrete, more punctate and short segment involvement of the cervical cord, whereas here MS, the neuromyelitis optica, it's longer segments. So almost about 3 vertebral segments are involved here. So this is unlike a MS. So this is a neuromyelitis optica.
The term we were introducing of neuromyelitis optica, we wanted to bring forward the very fact in this case that that's an important differential, increasingly being important in our country because reportedly the prevalence of NMO is relatively higher, in fact, compared to MS probably. But of course, we are still acquiring knowledge about that disorder. And the presentation would be a severe visual loss, often bilateral, which would be an atypical presentation, and absence of significant improvement. So even on treatment, they would not recover adequate vision. So that's when you start suspecting NMO. And the important thing is diagnosis is based on the anti-aquaporin 4 IgG antibodies, and of course MRI, particularly of the spine, where essentially you will have a normal MRI of the brain with affected MRI of the spine. So it's involving the optic nerve as well as the spinal cord, presenting to you like visual loss and lower limb or limb weakness.
Moving on to our next case. So he was a 12-year-old male presented with complaint of drooping of right eyelid for 2 years. There was a history of dizziness and headache. There was no other neurological deficit. On examination, as you can see, his vision was okay, but he had mild ptosis in the right eye with a smaller pupil in the right eye. So again, it has already been discussed that this could probably point towards the Horner syndrome. So we also revisited the history and we realized that there was history of absence of sweating of the right side of face and neck. So we obviously made the diagnosis of Horner syndrome and we went ahead with the evaluation. This is what we found on MRI thorax. Sir?
Just again the representative coronal and the axial images, T1 and T2. So this again shows a space occupying lesion in the right apical lung. On a coronal T2 weighted images, you see what looks like a beak here. If you go posteriorly, this beak was seen going into the spinal canal. So this is like a dumbbell tumor, partly inside the spinal canal and partly extending out, a mediastinal mass actually presenting in the right apex. Again on the axial, this is what you see with vessels around trachea in the center.
So the patient went ahead with the surgery and was diagnosed to have schwannoma. These are his pre and post surgical photographs. His ptosis as well as pupil also improved. This has already been discussed, so I would not go into the detail how to deal with anisocoria. Moving on to next
I
case.
think we may have to curtail the further
We'll just show the
presentation.
last case, and I
Yeah,
think that we'll
show
go.
the
This is the last case.
Okay.
and-
So this was a very interesting case. He came with the history of gunshot wound 1 month ago. There was a history of bilateral loss of vision, inability to open both the eyes, and there, on examination there was bilateral ptosis with absolutely frozen eyes. There was no movement. The vision was PL negative in both eyes. So we went ahead with the with X-ray. He had got this X-ray actually. It was done outside. There were number of pellets. So what would be the best modality to go ahead with this kind of picture?
Well, of course, CT. MR is not the modality, since if you have a metallic things in the brain or wherever in the scanning volume. So CT is, what you see here is that there are pellets. This guy was caught in the crossfire. So the bullets ended up being symmetrically right at the orbital apex. A very, very unusual event to happen in an unfortunate patient. So, and this on a images, the axial, the coronal and everything, all images when we saw, it was corresponding to the optic struts which separate the superior orbital fascia from the optic canal. So this is where they lodged.
Yeah, that's very interesting. Actually, you will never see such a case in your lifetime probably again.
Thank you very much. I thank all the speakers for making this session
Thank you.
very successful. Thank you very much.